I wanted to talk to you about some of the work that we're doing in developing interventions with an, focus on optimizing circadian health, but also looking at other physiological effects of light, such as acute alerting properties and mood enhancement, things like that. So this is my required disclaimer. All the ideas are my own, but the work is not. We have a lot of help doing these studies. And on the top row, you'll see my team. You'll notice some of their names appear as first authors, Sarah Bessman and Liz Harrison in particular. And then on the bottom row are our key collaborators for the work that I'm going to highlight today. Emily Schmid is at San Diego State University, and she really was important in bringing implementation science to the field studies that we do. And you'll hear me mention that a few times throughout the talk. And then Robert Solar, who is with BIOS Lighting and has really helped us up our game with the lighting that we're able to introduce into spaces. And then Kim Cully, who facilitated access to a really unique population and watch floor personnel. And so, as I said, these are the people that really helped with the work I'm going to talk about mostly. But I have to start, with the necessary introduction to why do we care about light? And, before we were making lights, light was made for us from the sun only. And, the solar light dark cycle is really important to our physiology. So it's worth introducing. Every day we experience a light dark cycle because of the rotation of our Earth. And then over the course of the year, there are seasonal changes in the relative proportion amount of light in each day. And all of that is really important. And we've evolved and adapted to it. And so we have a clock, right, that has approximately, but not exactly, a 24-hour period. We have a number of physiological and behavioral processes that fluctuate with that period. Things like our sleep-wake pattern, which we tend to focus on, but also hormone fluctuations such as melatonin and cortisol, like you see here. Core body temperature. There's a number that I'm not listing, but I just wanted to sort of give an example here so that we can see how these things relate to one another. So under normal healthy conditions, when we are synchronized to a 24-hour period and everything is in alignment, this is kind of what it looks like. Maybe not exactly, but we have, melatonin is high at night when we want to be sleeping. Core body temperature naders just before waking, cortisol peaks right after. And so these things sort of have a relationship to one another that's important so that we're doing what we need to do at the right time. Both physiologically and behaviorally. And the way this happens, is fairly well described. Light enters through the eye in mammals, and it's transduced into information that the brain can interpret via photoreceptors. And in the case of circadian regulation and other non-visual physiological effects of light that I'm going to be focusing on, there's primarily mediated by a subset of ganglion cells called the intrinsically photosensitive retinal ganglion cells, which I'm sure you've heard about over and over at all of the talks. They contain a photopigment called melanopsin. And so once the light information gets converted into the signal, it follows the retinohypothalamic tract from the retina to the hypothalamus, and specifically to the suprachiasmatic nuclei, which is the central pacemaker, central clock in mammals. And then there are a number of downstream projections within the nervous system that help serve to regulate our circadian timing system, but also neuroendocrine functions and these acute alerting properties, et cetera. You'll notice on the top of this diagram, we have the visual pathway. So that follows a separate track, more or less. And there is some crosstalk indicated by the dashed arrows, and they're even at the photoreceptor level. We know that the classical rods and cones, there's an interplay with them and these IPRGCs. But generally, these are kind of relatively separate pathways and different functions. And the focus had always been on lighting for the top system and not so much for the bottom. So that's become a problem. And we'll come back to that in a moment. But it's because of that physiology that there are a number of factors that influence how well we respond to light in these ways. And so, especially when we're talking about the circadian system, timing is critical. It varies systematically in terms of both the magnitude and direction by which light can shift the clock. When we get light, early in the night, it will delay us to a later time, which is indicated by the negative phase shifting on this first top left figure. And then later in the night, early in the morning, light will phase advance us to an earlier time. Now, at the same time, different intensities will cause a differential response. So as we increase the intensity of a light, we will get a greater response. However, it's not just linear. There's this sigmoid function. So there's a certain threshold amount of light that's required to elicit a response. And then there's a point where it maxes out and more light's not going to really make a difference. So within that range of responsiveness, at the same intensity, we will get a differential effect depending on the wavelength of light. So if we do these dose response curves, as we did when I was in Bud Brainerd's lab, at various wavelengths, we can then look at the half saturation point, which is the middle of that, right in the middle of that curve, that intensity dose response curve. And we can plot those ED50s as a function of wavelength, and that gives us what's called an action spectrum. And this is also from Bud's lab. This is the action spectrum for melatonin suppression in humans. And we found a peak spectral sensitivity in the short wavelength region. And subsequently, there have been a number of action spectrum studies looking across species and across responses, and they all show this similar peak in that short wavelength region. There are other factors such as directionality. So again, in Bud's lab, we looked at melatonin suppression when light was hitting just the lower or just the upper portion of the retina. And we found differences where light coming from above or hitting the lower retina was much more effective in suppressing melatonin as compared to the light that was coming from below and hitting the upper portion of the retina. And then there are history effects. And I'll just say this is the one figure that's not done in humans. This is work that I did in Michael Gorman's lab, where we looked at specifically photoperiod history effects in hamsters and found that animals that had been previously kept under a short photoperiod, like a winter day, responded with greater sensitivity to light. And this was for phase shifting. But I will say there have been a number of other labs who have looked at light history, including Bud and people like Chuck Seisler and so forth, that have found history effects in humans as well and different ways of looking at that. So we know, these are not as well described, I would say, the history and the directionality. And so the focus is very much on the timing, intensity, and wavelength, where we have a larger literature. But all of these factors, we think, have an impact. So, fairly recently, our field came together to develop a metric that would really reflect the biological potency of light. What had happened was a lot of people were reporting light in terms of photopic lux, which is how much is it stimulating the visual system. And the truth is you can have a relatively greater photopic lux and with a lower response, depending on all these other factors. So melanopic EDI, or equivalent daytime illuminance, which is also reported in lux, just to confuse things, was put forth as a way of weighting the intensity based on the spectral sensitivity for these responses. And soon thereafter, and fairly recently, recommendations were put forth in the context of that new metric, where people were saying we should be getting, humans should be getting at least 250 lux in terms of melanopic EDI during the day, and have some significant contrast to that in the evening and night, with less than 10 and less than 1 lux for evening and nighttime. And so this is, likely to be refined as we move forward, and it gives us a starting point, at least, though, to make some improvements and something to aim for and something to test. So you can see here some just pictures that I pulled. This is, our community. I'm at a medical school for military members, and we basically do a lot of our studies in service members and in hospital workers, who are also, a lot of them, military. And the 3 pictures on the left you can see are taken at times when people want to be awake and alert and working. And then the 2 on the right are in the birthing areas where people are supposed to be sleeping. And it should be really apparent that there isn't much contrast here. The working spaces tend to be below the 250 lux recommendation, and the sleeping areas tend to be brighter. And sometimes they're completely inverted, and people are getting more light when they should be sleeping than they are when they're working. And part of this is just proximity to the light source, but there's not a lot of thought being put into how these spaces are being illuminated. So it seems like low-hanging fruit, and we'll come back to that in a moment. But I want to just talk about, why we care. So here again is our nice circadian alignment that I showed you earlier under normal, healthy conditions. And here are a couple of examples where that's not the case. And so, if you're not getting any light and you're sort of just free running, you'll start to drift out of phase with the solar light dark cycle. And if you're getting, confusing light signals, you end up with a mismatch between the environment and your physiology. The middle is a case of, something like delayed sleep phase disorder, where someone, everything happens much later than when they might want to sleep and want to be awake because of social demands. On the right is a situation where now those rhythms are also shifted relative to when they want to sleep, but to varying degrees. And so you can see those arrows are out of alignment with one another. And this is an internal desynchrony. We've all probably experienced it when you have jet lag. It tends to be temporary, but if you're a shift worker and this is how you're living, it can lead to some negative consequences that, both acute and chronic, long-term sorts of things. So, I have a long list, and it's not even comprehensive, ranging from, being drowsy, having, depressed mood, or all the way to impaired cognition, impaired performance, mental health issues, cardiovascular health issues, impaired immune response, and so forth. So this list goes on, and we want to try to mitigate that. And so one of the best things we can do is use light. And it's kind of funny because it's, the signals, the light signals that are a problem are also what we can use as the solution. And we can use it to do a number of different things, right? We can use it to try to phase shift the clock and to entrain the clock better. We can use it to acutely alert somebody. We can use it to regulate hormones. We can use it to improve mood. And the fact of the matter is, if we're using it to address one of these things, we have to know that we might be affecting some of the others. And I'll come back to why that's important too. But, we have a good number of studies showing that light can be an effective countermeasure in those ways. But when you look at the larger literature, it's kind of inconsistent, and it's often limited when it's, you're looking at one particular application. And so these are just a few reviews and meta-analyses that look at, lighting interventions for shift workers or lighting interventions for, and in this case, I think patients for dementia. There are a number of these papers, and sort of at the end of the day, they're always like, well, in the field, things are just noisy, and there's a lot of differences in methodology, and it's not very specific about, what's really happening often. So I want to call out a few things that I think are happening, partly because, we do the lab studies too, so we know what we're doing and we know what doesn't always translate over into the field. And one of the things, as I kind of mentioned when I was talking about how we can use lighting as a countermeasure, is light will affect all of these things potentially. And when we do the lab studies, we're not always examining multiple outcomes. Sometimes we're very focused. Like when I was in Bud's lab, we were looking at melatonin suppression. We weren't looking at phase shifting. It wasn't set up to do that. We weren't looking at alerting or mood or any of these things. And so I think that's an important thing, because for example, shift worker intervention, we may want to alert somebody without shifting their clock or without suppressing melatonin that maybe is increasing their risk of certain hormone sensitive cancers, as an example. And so there aren't a lot of studies that look at multiple responses, but that's not to say there aren't any. And this one study that I have the figures from Vanderwerk and Marika Gorgin's lab really intrigued us, because they looked at melatonin suppression by light, and they, compared to a dim control condition, two different lighting conditions. One was a bright white fluorescent light, and one was that same light, but trying to filter out the blue energy in that light. And what intrigued us about this is you can see for melatonin, in that case, the bright white light is suppressing melatonin, but the blue filtered light doesn't look different from the dim condition. But when they look at performance on a math task, we get this dissociation where, the dim light is not performing very well, but the two lighting conditions are statistically equivalent. And so here's a situation where they've got this sweet spot where they were able to, improve performance without suppressing melatonin with this particular lighting condition. And I think that this seemed like there's, a lot of utility in an intervention like that. The other thing with our lab studies is that, they're not usually ecologically valid, right? Because we're trying to control everything. And so one example of that from the studies that I did in Bud's lab is we mostly pharmacologically dilated the eyes so that, we were optimizing the exposure across people and reducing some of the variability, individual variability in pupillary response. But in doing that, people aren't going to have their pupils dilated in the real world. You can't do that all the time. And so we did go back and we did a study where we looked at the dose response to light within participants with their pupils dilated and then with them freely constricting. And what we found is that when their pupil was free to constrict, they weren't as sensitive to light. So the ED50 shifted to the left. And also the steepness of the curve is different. And that's because what's happening as the more light they're getting, the more it's constricting. And so they're not getting, that same additional benefit. It's a little bit slower to make a difference. The other thing that happens with these lab studies is they often don't employ what are really practical exposure conditions. And so I'm thinking about some of the phase shifting studies that have been done in humans where, they're administering 6.5-hour pulses. A lot of times, at least in our populations, we can't really get them to use light. An hour would be pushing it. And so we've gone back into the lab to start looking at much shorter exposures to see what happens in terms of bang for your buck. If you keep the dose of light the same, what does it look like at 20, 30, and 60 minutes? Can we get the same effect with a 20-minute exposure that's just brighter? Or are there diminishing returns because this is pretty bright? So at this point, is there a lit aversion that's blocking some of the light out because it's, too much, or, because of the glare or things like that? And we're also looking at time of day and how that might interact with these things. So that's one thing we went back into the lab to do, because we knew that maybe we can get a 30-minute lighting intervention into certain situations, and we don't know how to optimize that exactly. The other thing that often happens, again, I'll use bud studies are wonderful, and I feel so fortunate to have been in them, but I'm picking on them a little bit today because, we try to translate from that data, and then if it doesn't translate, we wonder why, but there are a lot of reasons why that might be. So another thing that we did in those studies, and a lot of human laboratory studies do, is, you do your lighting intervention, you do your post light exposure assessments, and then the study is done. And we don't always know what happens after the light is extinguished. And you think about something like, a sugar rush, where you kind of, you get a rush, but you crash and burn, versus caffeine, which has a very long half-life. And what does light look like, after it's extinguished? What's the trajectory, and does that change depending on the characteristics of the light that we know make a difference in terms of the time of day, in terms of the duration, in terms of the wavelengths, et cetera? And, we know we have hints from some of this work that has been done that that may be the case. But anyway, we've gone back and we started to look at that systematically by, altering these different photon doses and times of day, and then continuing to look at how are people responding to the light in the hours after the light goes out. This is just our control data. And you can see on the left, the Karolinska sleepiness scale, which is just how alert or sleepy are you. And on the right is the psychomotor vigilance task. I'm getting tongue-tied with these. And the reaction time on that. And you can see that for both of these, in the beginning, they kind of start out, the same between the AM and the PM. So this is where I can't really tell what the shapes are, because I can't see that good, but I know what it is. So in the PM, we see people actually get sleepier faster and perform worse faster than in the AM. And this AM PM is anchored to their sleep times, or their wake times. And so we're starting to see these differences in time of day. And again, this is just the control, but we'll have light exposure data that we can analyze soon. And again, this is preliminary, only 12 people and unpublished, but I wanted to share with you some of what we're looking at in the lab. So the next thing I want to start doing then is talking about how we think about interventions when we're going into the field. Because it's a little bit of a different way of thinking about things, and it's much more practical. So, one thing we think about are, what are the technologies that exist? And there are a lot, and they're growing rapidly, the options, which is great. But I just have a couple of different types of lights that I want to talk about, pros and cons. So on the left, you'll see architectural examples for ceiling fixtures and these fluorescent tube bulbs, which are still used. In the middle, you see a couple of portable light options, or, tabletop type of lighting, a light box, which is traditionally used for treatment of winter depression, and a desk lamp that has a dynamic system. And then on the right are these wearables that either emit light or shape light in some way. So when you're thinking about architectural lighting, the advantage to that is you don't have to worry about compliance, because if the lights are on and someone's in that space, they're exposed to it. But from a practical standpoint, it's trickier to install these things, because you need to coordinate usually with the leadership or management in that space, as well as facilities, and sometimes even more than that. So sometimes that's a trickier thing to do. And of course, if there are budget constraints, that's another, obstacle that you might run into. The portable lights are kind of a tweener, because they do require some level of compliance. People in the space might get some of it, but really it's directed at an individual. And so it's harder to give everybody the same light levels in that case. Maybe each individual light is cheaper, but it could get expensive quickly depending on the light that you're using. And it does require some level of compliance, not to the same extent though as, and also permission, right? Because you're bringing something into the space. But usually it doesn't require like facilities involvement, sometimes, but not usually. And then with the wearables, the nice thing about those is really the capability of individualizing exposures. And especially if you're talking about a heterogeneous population in terms of circadian phase, like shift workers. So you can control who gets what when. That's a real advantage. And the problem with it, of course, is now it requires behavioral change. People have to use these things and they have to use them properly. And we know the timing is important and it's probably part of the intervention if you're using this. And so that part gets tricky. But it has the advantage of being individualizable. And a lot of these things are pretty cheap, like sleep masks, and even the blue blockers tend to be cheap. So anyway, those are some of the things that we think about. And as we learn more about what we want to do, we can make what we want. I remember being at a Department of Energy lighting division meeting and the lighting engineer saying, well, we can make whatever you want. We just don't know what that is. And that really struck me because I'm like, all right, well, let's see what you can make. And really, they can make some really great lighting. So on the left is a study from 2020. It was published in 2020. We probably started collecting the data 2 or 3 years before. And at that point, we didn't have the budget to create our own lights. So we just looked to see, well, what was commercially available, the best commercially available lighting that fit within the ceiling fixtures at the hospital where we did the study. And you can see the spectral power distributions for the light, I think, are in dark blue. I have the action spectrum in the light blue so that you can see how much these spectral power distributions overlap with the spectral sensitivity function. And then I think the black or gray is the baseline, the lighting that they already had in place. And you can see that for the commercially available lighting on the left, it's not a huge boost. We don't get a big difference. What is it? 130 to 162 melanopic EDI. So it's an improvement, but it's not a huge improvement. And it's accompanied by a change in color temperature that is in the wrong direction. People tend not to like these higher color temperature bulbs, which look more blue too. And so it was sort of, people aren't going to like it as much and it's not really doing as much compared to on the right when we got the budget to design our own lighting and had help from Robert Solar. We were able to make much more beautiful lights that you can see overlap significantly more with the action spectrum and are giving us quite a bigger boost in terms of biological potency. And in this case, we went from 98 lux melanopic EDI to 321. So, and with a reduction in the color temperature to a warmer color that people tend to like. And I'm going to show you more on that light in a moment. But before I get there, I just want to say one last thing, which is that, and this is the Emily Schmid brought us this, the implementation science. And we did a review, which I show here, to look and see, how often are we using this in our own field studies, in our field. And it's really an underutilized thing, and it's so super valuable. Even if you do one of these studies in the field and you don't get a lot of effects because maybe you didn't have enough power or there's, because there's so much noise and whatever, this implementation data is gold. So, when I talk about implementation, I'm talking about things like usage patterns, ease of use, planned future use. What do people find it comfortable? Are they satisfied with it? Do they think it's working? Because really, at the end of the day, even if we find that it's effective, if these things are problematic, they're not going to use them anyway. And so I think this is really important for us to understand. And as we're doing these studies, we learn, and then we can refine the interventions that we develop in the future by tweaking a lot of the things that really don't even have to do with the light in some cases. Then maybe it's the form factor of the light, or the glasses that they're wearing, the aesthetics of them, or how they fit with the CPAP. And we'll talk about that in a minute. So this is the first study that I wanted to highlight, and this is, you'll see, a hybrid effectiveness implementation study. And this is kind of a type of study where it's very heavy on the implementation science, but you're also looking at efficacy. And in this case, we developed 2 spectrally engineered light sources with Robert, 4 shift workers that were on a high security watch floor. And on the left is a diagram of what that watch floor looked like. On the right is a photograph of a watch floor that looks almost the same. But because of the high security nature of this space, we were not allowed to bring a camera in. We couldn't do any recordings. We couldn't bring any electronic devices, period. No phones, no tablets. So all of our assessments had to be sort of modified to do this study. Everyone filled out KSSs on paper slips and put them in a box. So it was really kind of a throwback study for us. But you can see how it was configured. There are a lot of monitors in the space because this is, that's what they are, security, watching. And you can see what we did was we took light boxes and set them up in the front of the space because that's what we were able to do. And again, weighing all these things that I had mentioned earlier, it was the best way to introduce new lighting into their space. The dotted squares represent workstations where they spent most of their time. And really the front row, the top of that left diagram, is where the vast majority of the personnel worked. Leadership sat in a row behind them. So we'd had only 1 or 2 people back there. So we were able to really create a fairly similar lighting experience across the watch floor personnel. And I already showed you what we call our SW plus, our short wavelength enriched condition, where there is a lot of overlap with the action spectrum. That's the top condition. But we also, based on the study I showed you, the van der Werken study, where they dissociated by blocking the blue light, we wanted a short wavelength depleted condition. And so we had this light that was not overlapping very much with the action spectrum, but it was designed to be very similar in appearance and visual stimulation to the short wavelength enriched. So they weren't exact, you'll see, but they were very similar in terms of photopic lux. They were about 300 lux. And in terms of color temperature, they were about 3000 Kelvin. But in terms of melanopic EDI, they were very different. And with the short wavelength enriched condition, we had a melanopic EDI of 300 lux, which puts us above the daytime recommendation of 250, whereas the short wavelength depleted was only 100. For both of the conditions, we had participants wear blue blockers at the end of their shift and then eye masks during their sleep. And this is sort of the protocol for how it was set up, which is a little confusing, but there were 4 teams that were on staggered schedules so that they would have continuous coverage throughout the day and night. So they were on 12-hour shifts. Half of them were off on any given day, and the other half worked either a day or a night. And this is just an example of, say, one team where they were on for 4 days on a night shift schedule, then they get off for 4 days. Then they were on again, and then they were off. And for the first 4 days, they had their baseline condition. For the second 4 days of night shift, they had the short wavelength enriched. And half of the teams, the order was flip-flopped, basically, so we can look at order effects. For the second 16-day block of night shift schedules, they had the short wavelength depleted, or the baseline first, and then the other conditions. So they were all given 2 baseline conditions and then both of the lighting intervention conditions. Again, For both of the lighting intervention conditions, they also wore the blue blockers and the sleep masks, and we had them continue to do that on days off so that we could look at if that helps without the light. And then, we did actigraphy. We did get permission for them to wear actigraph watches, but the light sensor data isn't great because they are military. They wear uniforms and the sleeves cover it, in an unpredictable way. So it was garbage data, honestly. But we did get a lot of, static measurements in that space, and that's really well characterized and reported in the paper. They did a daily diary. We need that with actigraphy. And we had them do the KSS and the PVT at the beginning, the middle, and the end of their shift. And then we had an extra KSS afterward that was done via text. But when they were on shift, we couldn't send them messages or anything. They weren't allowed to have phones there either. So they would have to step out of their space, their workspace, in order to do the PVT. And what happened was the beginning and the end of the shift were transition times for everyone in the building. And it was a very high traffic area where we had to set up our tablets. So we ended up really only being able to use the middle of the shift PVT data. So we're really underpowered there, but I'm going to show you the data that we did get. So first, we're looking at sleep here. You can see there are no differences in total sleep time across the conditions, but we do see differences in waking after sleep onset and sleep quality with improvements in the short wavelength enriched condition. We see a reduction in sleep onset latency for the short wavelength depleted condition. And then, all the other comparisons are statistically similar. We also, with the short wavelength depleted condition, see improvements in alertness by the Karolinska Sleepiness Scale. And you can see that from the beginning to the middle to the end of the shift, they get sleepier and sleepier, which is kind of common for night shift work. We see that across settings, but they just didn't get as sleepy to the same degree in the short wavelength depleted condition. For PVT, the reaction time looks the same. The PVT errors look different, but look at the scale. I mean, we don't have a lot of errors, and we were underpowered. I suspect that if we were able to collect more data, we might actually start to see something there. One thing that we ask, so because, we see this improvement in alertness with the SW minus, we need to know like what's going on. People use caffeine all the time and when they're doing these night shifts. And so we tracked that based on report, but we have really good participants in terms of compliance. It's something we actually don't really have to worry about too much, but it's not real. It's our artificial military regimented sort of culture. But anyway, in terms of caffeine, the SW minus condition, people used caffeine less, which made us think that this is likely due to the light and not, for another reason. And it's consistent with them feeling more alert and not needing to caffeinate as much. They also reported better quality of life. And again, a subjective assessment, but, overall and in the health domain, people reported better quality of life with the SW minus condition. In terms of things like symptoms attributed to the light, we ask about this often. We saw, that both interventions were better than their baseline in terms of things like glare, headache, nausea. Nausea actually wasn't different, but the others were, and fatigue. And so in this case, both the SW plus and the SW minus outperformed their baseline. When we ask about feelings attributed to the light, people report less negative feelings and more positive feelings with the lighting interventions as compared to their kind of normal lighting situation. And when we ask about their experience with the lights, people feel satisfied and comfortable, and they also report less brightness with the lighting interventions, which was interesting because, for the lighting interventions, we did not change their normal lighting. It stayed the same. They had their same terrible overhead fluorescent lights, and all the spots of light from the monitors. But what we think is happening here, is, glare is reduced by having these light boxes in the front of the space. And so it appears less bright. The light appears less bright to them. We also ask about their experience with the other tools, the blue blockers and the sleep masks. And you can see that, they thought that their sleep either stayed the same or improved by using these tools. In terms of ease of use, they found them easy to use, but we start to see differences between these things when we ask about the likelihood of future use. And most people actually say, they might actually use the sleep masks, but the blue blockers were very split. And it tended to be either an aesthetic thing. People don't like how they look while they're wearing them and they don't want people to see them, or they think they just won't remember to do it. Whereas the sleep mask, they can just put it on the bedside table. Or it's a compatibility thing. If some of the people are gamers and they said it interfered with their ability to play their games when they got home. And for the sleep masks, there were less people who were opposed to wearing it in the future, but the reasons why were, again, either they said it falls off when they're sleeping, which was annoying, or they felt like it didn't fit well with their CPAP. We have actually a lot of people with sleep apnea. And so, it's something to keep in mind in the future when we're looking at these tools, how can we adapt them and give them choices that are going to work best for them. Okay, so this brings me to the next study that I want to highlight, and I'll highlight this briefly so we have some time to chat. But when we were doing these studies, we realized, people do what we ask them to. We're lucky in that way. And, sometimes they'll do what we ask them to because there's some, financial compensation. So they're incentivized in that way, or it's just because, they think it's cool to be part of a study, or, whatever the reason. These are extrinsic motivators, and we want them to want it. We want them to want to continue using these things after we're gone. So we felt education was really important. And when we looked around to find something that was ready-made, we didn't really see what we wanted, because we felt we really wanted to emphasize circadian health and lighting. And a lot of the sleep hygiene programs kind of touch on it, but not in the way that we had hoped they would. So we developed this program called the Circadian Light and Sleep Skills, or CLASS for short. And in this case, we have an implementation component, but we did that early on. We published 2 papers separately. One talks about how we developed the program, and looked at feasibility and some pilot data to help refine it. And then the other one was really our study of the efficacy of this program for improving sleep. And the way this program was different from other programs is, rather than a focus on sleep and the bedroom environment, or just, the short period preceding sleep, we start with when you wake up. And it's not anchored to time of day. It's anchored to your own sleep-wake cycle, just because we have a lot of shift workers. And we basically go through the day and what they should be doing when, in order to get good sleep when they finally want to sleep at the end of their day. So it, covers things like maximizing light after waking and how to do that. Using caffeine judiciously, both in timing and in dose, so that you don't, lose its effects. But you also, and you're not using it in a way that's going to interfere with your sleep and create this vicious cycle. Programs like CBTI are really great, but they also say no napping. And we felt like a lot of our people don't get enough sleep. And so we want them to nap. We want them to make up for whatever sleep they can. It's not going to be, they can't really make up for it, but if they're sleep deprived, we'd rather them nap than not. And we talk about, a short nap versus a longer restorative nap where you cycle through, but then you might have sleep inertia when you wake up. And so planning for that We talk about exercise, and this is a way to really get people engaged because they care about their fitness. And so optimizing performance based on what we know about circadian effects of exercise, but also, urging them not to do it too close to bedtime so it doesn't interfere with that. We talk about alcohol and limiting it and how it changes your sleep quality. And so maybe it helps you fall asleep, but maybe, you're not going to get as good sleep. We talk about keeping a regular bedtime, and we also do the normal sleep hygiene stuff, which is maximizing the sleep environment. And we go a little bit more in depth about how to do that, how to it's really brief here, but we talk about how to use dark out curtains and sleep masks or software that takes the short wavelength energy out of your devices and all sorts of things. We also highlight things that are not time dependent, and they're kind of peppered throughout, making sleep a priority and why they should be doing that, how to maximize safety when they're not getting sleep. So we acknowledge that they're not always going to, but as soon as they can, they should come back to it. But, trying to really prioritize safety in those cases. And then, keeping your schedule as regular as possible. So we talk about, doing that on weekdays and weekends, or, work days and off days, and social jet lag and things like that. And then, if they're doing all of these things that we're asking them to, and they're still not getting good sleep, then we urge them to see a physician. So this is not a clinical program at all, not like I mentioned CBTI. It's different because these are people that we're trying to catch before they develop a sleep disorder. But, it's a little bit of a different approach than what we've seen anyway, taken before. So in terms of our, developing this, one of the things we wanted to know is, what are people learning from our program the most? What are they going to use, and what are they going to share? And you can see, these pie charts are, the largest piece of the pie has to do with light exposure. So this was told us that we were on the right track by focusing on it because it was novel to people. And they felt it was something they actually could use. So it gave them some agency, and they wanted to share it. So, hey, if we start giving this program to people, it may spread beyond those that we are interacting with directly. And that's a good thing. So now I'm going to show you some of the efficacy data. When we looked at the outcomes of our program, we wanted to know, did they learn what we wanted them to learn? Did it change their behaviors? Because maybe we need to present it differently if they understand it, but they still don't do anything differently. And then ultimately, is it change their sleep? And so time point 3 is 2 months after we did the program for them. It's a 30-minute presentation with some text-based reinforcement of some of the main principles that we want them to remember. And you can see that the closed circles are the group that got the intervention, and the open did not. And knowledge went up in our intervention group. Behaviors improved, and sleep quality improved as well. It's a little bit deceiving, but Pisky lowers better. So, so all these things happened, which was great. And this was without any changes in their lighting. It's just the education. We also explored how some of their mental health symptoms looked with this program, and we found that the sleep quality mediated improvements in all these mental health outcomes of depression, anxiety, and PTSD. So this is maybe another way of addressing other issues that have some stigma attached to them and are really hard to address, especially in service members. Finally, we always ask about satisfaction and perceived relevance, because it makes us feel good when people like these things, but we want to know if they don't, and if they were very high. They really felt they were relevant. I think there is a desire to get this information and to figure out ways to help with their sleep. We're at that point, which is really good in a culture that used to see sleep, lack of sleep as sort of a badge of honor. Okay, so I'll just quickly summarize. I can't really read my own writing, but I think basically, there are a lot of questions that remain to be answered in the field and in the lab, but we also, I think, know enough to start making improvements in things. We have a lot of off-the-shelf products and a growing number of them, but I think there are improvements to be made upon those. And I showed you how even with, what we know right now, we're able to improve sleep, alertness, performance, quality of life, mood with these interventions. All of the interventions so far have been perceived as easy to use. They've been well received. So I think there is, demand for these things, which is really good to see. Um, I'll say it one last time. I think the implementation measures are gold. It's something we should all be collecting as we do these studies. We've started to incorporate them into our lab studies even because it's really interesting and helps us refine our interventions at the earliest stages possible. And then finally, there are always limitations in the methods that we can employ, and we just really kind of need to be flexible, get the data that we can get, and then look at it all together as a whole. Okay. I'm going to skip future directions. I'll just say, we would like to do a lot of, extend on this work. We'd like to see other people extend on it. We'd like to see generalizability across different populations. Right now, we've got a very select, unique population that we've been focused on. I think a layered approach is the future, using all these components that have different pros and cons, as I talked about earlier with the architectural to the wearables. We think that combining the lighting interventions with education is going to be key for people actually using them in the future, and figuring out how to scale up, which is going to be a challenge. I already said everyone who helped with this stuff, you can see our funding sponsors on the bottom right. But I will now just thank you and invite any questions or comments that you might have. I'll stop sharing.